Hello, everybody. Welcome to this new lecture series, Epidemiology for Medical Doctors. This is episode 1, The Lens Shift. All right, let's get started. So what exactly is epidemiological research, and why should you, as a medical doctor, even care? Not why should a public health official care, not why should a statistician care, why should you, as an MD, care? Because medicine is full of traps. A patient comes in with an MI at age 44. Another is 78, smokes like a chimney, and somehow never had one. One ward seems full of C. diff after broad-spectrum antibiotics. Another hospital has a shockingly high post-op infection rate. A paper claims a drug reduces mortality. Another paper says the benefit disappears after adjustment. A third paper says the first two were asking the wrong question in the first place. And that is exactly where epidemiology enters the room. Clinical medicine asks, what does this patient have, and what should I do now? Epidemiology asks, who gets this disease, how often, why, under what conditions, and what can we do to prevent or reduce it at the population level? Well, if you strip away the lab coats, conference badges, and the 10-tap statistical software suffering, epidemiology is medicine learning how to think beyond the one body in front of you. It is how we move from I saw this to this is a pattern to this pattern is real to this pattern has a cause to we should change practice because of it. And that's what this whole series is about. By the end of this series, the goal is that a doctor should be able to design, read, execute, analyze, and write a serious epidemiological research project. That is the promise of the series, and this is the first lecture in the foundation stone. So today we're going to do 5 things. First, define what epidemiology actually is. Second, explain why MDs should care. Third, separate epidemiology from clinical medicine, biostatistics, and public health, because people love mashing these together in one conceptual soup. Fourth, talk about what makes a study important. And fifth, distinguish between curiosity, evidence, and publishable research. And along the way, I'm going to use a few classic papers, so this doesn't become one long definitions funeral. Okay, let's start simple. A standard definition used by the CDC describes epidemiology as the study of the distribution and determinants of health-related states or events in specified populations, and the application of that study to the control of health problems. CDC also describes epidemiology as the basic science of public health. That definition sounds neat and polished, but let's break it down into human language. Number 1, distribution. Distribution means who gets the disease, where does it happen, when does it happen, that is, person, place, and time. If lung cancer is more common in one group than another, that matters. If cholera clusters around one water source, that matters. If influenza spikes seasonally, that matters. And if maternal mortality is higher in one hospital than another, that also matters. Number 2, determinants. Determinants are the factors associated with disease, health, or outcomes. Exposure, behavior, environment, genes, healthcare access, socioeconomic conditions, treatment patterns, policy, culture, sometimes microbes, sometimes systems, sometimes both because the universe loves complexity. You are no longer just asking what happened. You are asking why it happened and what changes the probability that it will happen. Number 3, specified populations. This part matters more than people realize. Epidemiology is not about vibes. It is not about people in general. It is about clearly defined populations. For example, adults with diabetes in Lebanon, ICU patients receiving mechanical ventilation, women aged 50 to 69 in a breast cancer screening program, HIV-positive adults on ART, residents of a refugee camp during a hepatitis A outbreak. The population is not decoration. It is the stage on which the whole question lives. And fourth, application. This is the killer part of the definition. Epidemiology is not just academic bird watching with disease. It is supposed to lead somewhere. prevention, screening, policy, resource allocation, guideline development, risk prediction, or better study design. If your work has no possible application, it may still be intellectually interesting, but epidemiology at its best is interested and useful. Now, let me say something that will save you years of confusion. Epidemiology is not just outbreaks. A lot of people hear epidemiology and imagine somebody in a vest running after Ebola. That is one part of it, a very dramatic one, very Netflix. But epidemiology also studies cancer survival, cardiovascular risk, vaccine effectiveness, psychiatric outcomes, treatment harms, healthcare disparities, diagnostic accuracy, environmental exposures, and social conditions that shape health. CDC's own public health materials explicitly frame health as being influenced not only by medical care, but also by non-medical conditions in which people live, work, grow, and age. So, if you are an oncologist, cardiologist, internist, surgeon, pediatrician, psychiatrist, family physician, or medical student trying to publish without losing your mind, yes, epidemiology is your business. Okay, now let's get personal. Why should a doctor care? Because clinical medicine without epidemiological thinking is, in my humble opinion, very vulnerable. You can be brilliant at diagnosis and still be fooled by literature. You can also know every guideline and still not understand where the guideline came from. You can memorize hazard ratios, odds ratios, sensitivity, specificity, and p-values like a very elegant parrot, and still miss the central question: was this study actually asking and answering something real? Doctors need epidemiology for at least 5 reasons. Reason number 1, to read papers without getting manipulated. A very huge amount of medical authority comes from published research, but papers are not holy texts. They are arguments. Some are excellent, some are flawed, some are basically statistical cosplay with a nice abstract. Epidemiology teaches you how to ask, what was the question? Was the design appropriate? Was the population right? Was there confounding? Could bias explain this? Is the conclusion bigger than the data? That is intellectual self-defense. Reason number 2, to ask better questions. Most beginners in research do not fail because they are lazy. They fail because the question is mush. They ask, is this disease associated with bad outcomes? That is not a research question. That is a fog bank. Epidemiology forces precision. In which population? Compared with whom? Measured how? Over what time? With what outcome? A sharp question can rescue a mediocre dataset. A blurry question can kill a beautiful dataset. Reason number 3, to understand risk. Medicine is obsessed with risk, even when it pretends not to be. Risk of disease, of recurrence, of mortality, risk of bleeding, risk of progression, risk of hospital readmission. You're going to hear this all the time on the wards. And risk is not experienced the same way at the bedside and at the population level. A patient, for example, asks, will this happen to me? Epidemiology helps us answer, here is the pattern among people like you. Here is the uncertainty, and here is what shifts the odds. Without this mindset, medicine becomes intuition wearing a stethoscope. Reason number 4, to connect the individual to the system. A clinician sees a patient with uncontrolled asthma. An epidemiologist asks, is this about adherence, air pollution, housing quality, healthcare access, medication cost, smoking in the household, seasonality, neighborhood deprivation? That is not abstract public health fluff. That is clinically relevant reality. And reason number 5, to become a more powerful researcher. If you want to publish serious work, especially as an MD, epidemiology is the spine. Even when your paper is clinical, quote unquote, the skeleton underneath is usually epidemiologic. You're talking about study design, sampling, measurement, bias, confounding, follow-up, outcome definition, comparators, analysis, inference, and what have you. You do not need to become a full-time epidemiologist to benefit from epidemiological thinking, but you absolutely need enough of it to stop stepping on rakes. I think that this is one of the most useful distinctions in the entire series, so let's do this properly. Clinical medicine is centered on the individual patient. You take history, you examine, you diagnose, you estimate prognosis, you choose treatment, you adapt in real time. Clinical medicine asks, what is happening in this person right now and what should I do? That question is sacred. It is immediate. It is high stakes. Epidemiology, however, zooms out. It asks, who develops this? At what rate? Under what conditions? What predicts it? What exposures matter? What intervention reduces it? How certain are we? Now, clinical medicine saves the person in front of you. Epidemiology helps prevent, explain, and improve outcomes for groups of people, including future patients you have not even met yet. CDC's definition explicitly emphasizes populations, determinants, and application to control health problems. Biostatistics, on the other hand, is a different thing. Biostatistics is the quantitative toolkit. If epidemiology is the strategy, biostatistics is the weaponry. Biostatistics helps you estimate associations, quantify uncertainty, model outcomes, handle variability, and avoid fooling yourself with randomness. But biostatistics is not the same as epidemiology. Epidemiology asks whether the question, design, and measurement make sense. Biostatistics helps quantify the answer once they do. As for public health, it is broader. It includes prevention, surveillance, implementation, policy, systems, community interventions, health promotion, and social conditions that shape health. CDC materials on social determinants explicitly include education, economic stability, neighborhood context, and access to care as influences on health outcomes. So here's the clean version. Clinical medicine asks, what should I do for this patient? Epidemiology says, what patterns and determinants explain disease in populations? Biostatistics says, how do we estimate and test these patterns rigorously? And public health says, what do we do at scale to improve health? Oh, and one more thing, because I think this really matters for MDs. A lot of doctors think epidemiology is less clinical than medicine. No. It is upstream of a huge amount of clinical medicine. Screening recommendations, epidemiology. Risk calculators, epidemiology. Vaccine effectiveness, epidemiology. Outcomes research, epidemiology. Comparative effectiveness, epidemiology. Prediction models, epidemiology plus stats. Even large parts of evidence-based medicine are epidemiology in a suit. So the goal is not to choose between clinician and epidemiologist as identities. The goal is to become a clinician who can think epidemiologically, and this combo, I think, is dangerous in the best way. Okay, so now we've come to my best part of the lecture. We're going to talk a little bit about history. So I think before we start talking about odds ratios and cohort studies and randomized trials, bias, confounding, and all the beautiful monsters of epidemiology, I think I would love for us to step back for a little bit, because medicine did not always think the way it thinks today. For centuries, medicine was mostly reactive. When a patient gets sick, the physician observes, treats, records, and maybe tells a story afterward. That is clinical medicine at the bedside. Important, humane, necessary, but epidemiology gave medicine something else. Something very different. It gave medicine the ability to zoom out, as we've mentioned. So instead of asking only what happened to this patient, epidemiology asked, why are these patients getting sick in the first place? What patterns exist before the disease appears? Can we predict who is at risk? Can we intervene before a disaster happens? And do these patterns hold across the entire world? This slide shows 4 historical anchors that changed how modern evidence works. First, Dahl and Hill in 1950 with smoking and lung cancer. This was the birth of the association. Then the Framingham study with the invention of the risk factor. That is basically medicine learning to predict future disease. Then we've got the physician's health study, where randomization moved us from observation to experimental evidence in humans. And finally, the inner heart in 2004, which asked a massive global question. Do cardiovascular risk factors behave similarly across countries, cultures, and continents? So I wanted this to be like a journey of modern medicine, from after-the-fact storytelling to before-the-event prediction, from this patient had cancer to this exposure may cause cancer, from this patient had a heart attack to this person has a measurable future risk, and also from this drug might help to we randomized thousands of people and tested it. And also going from this seems true in one country to does this travel across the world? I think this is the intellectual engine of epidemiology. All right, perfect. So we're going to talk about the birth of the association. We'll begin talking about Dahl and Hill in 1950. I think this is one of the greatest detective stories in medical history. At the time, in the 50s, lung cancer rates were rising dramatically, but medicine did not yet have the epidemiologic reflex we have today. Because today, if a disease suddenly increases, we immediately asked what changed in the population, what exposure became more common, what behavior or environment or occupation or treatment might be linked to the outcome. Back then, this way of thinking was still developing. Dahl and Hill asked a very simple but revolutionary question. Could smoking be associated with carcinoma of the lung? Notice the wording. They were not yet saying smoking causes lung cancer with full confidence. They were asking whether people with lung cancer differed systematically from people without lung cancer. This was the birth of analytic epidemiology. The core move here was comparison, not just describing patients with lung cancer, not just saying here are some cases, but comparing exposure histories between groups, those with the disease and those without the disease. This was the key leap. So medicine moved from collecting dramatic stories to testing population-level explanations. And that is why the study matters so much. A case report can say this patient smoked and developed lung cancer. But epidemiology says, let's compare many patients with lung cancers to similar patients without lung cancer and ask whether smoking is more common among the cases. That sounds obvious now. I'm sure it does. But at that time, it was a complete change in the grammar of medical thinking. I think that Dahl and Hill gave medicine one of its most powerful sentences, that disease may not be random. Disease may be patterned. And if disease is patterned, we can study the pattern. That was the birth of the association. I strongly recommend that everybody read this paper. I'm going to put the link to the paper in the description box, but I think it's one of the most revolutionary papers in the history of modern medicine. All right, now we move to Framingham. If Dahl and Hill helped medicine understand association, Framingham helped medicine understand prediction. Because before Framingham, cardiovascular medicine was often reactive. Okay, you'd get a patient who would die from a myocardial infarction, or a patient died suddenly. Okay, the doctor responded after the event had already happened. And most of the time, we know that that could be too late. But Framingham asked a revolutionary, different question. What if we followed people before they become sick? What if we take a population free of coronary heart disease, measure their characteristics, and then watch what happens over time? Again, today this sounds super simple and so intuitive, but trust me, at that time, that was conceptually enormous. It was enormous. Instead of starting with disease and looking backward, Framingham started with healthy people and looked forward. That is, of course, what we now call the difference between retrospective explanation and prospective prediction. In short, the study followed over 5,000 people who were initially free of coronary heart disease. And over time, investigators looked at who developed disease and what characteristics predicted it. Now, they talked about stuff like blood pressure, cholesterol, electrocardiographic abnormalities, smoking, diabetes, age, sex. These, of course, later became the raw material of what we now call risk factors. And I think this is, again, one of the most important concepts in modern medicine. And because we know that a risk factor is not just a random clinical detail, it is in fact a measurable characteristic associated with the future probability of disease. And again, this is why this study changed medicine. After Framingham, a person could walk into a clinic feeling perfectly fine, never feeling better, and yet the physician could say, with high confidence, your blood pressure is elevated, your cholesterol is high, you smoke, you are not sick today, but your future risk is higher. This is predictive and preventive medicine. Framingham turned the invisible future into something clinically visible. That is almost magical, not magical in the supernatural sense, but in the scientific sense, because we're taking measurements today and using them to estimate tomorrow. And once medicine can predict, medicine can prevent. So this slide shows one of the most important lessons from Framingham, in my opinion. It says risk factors do not politely stand in separate corners. They stack, they interact, they compound. Here we see the 6-year incidence rate per 1,000 population among men aged 40 to 59. If all three major characteristics were normal, the incidence was around 35.8 per 1,000. If one was abnormal, the incidence rose to about 103.4 per 1,000. That is almost triple. If two were abnormal, the incidence rose to about 204.1 per 1,000. And that is not a tiny increase. That is a risk explosion. The three characteristics shown here are elevated serum cholesterol, definite hypertension, and ECG evidence of left ventricular hypertrophy. This is where epidemiology becomes clinically powerful. Notice that it does not just say high blood pressure is bad. It says high blood pressure plus high cholesterol plus evidence of cardiac strain creates a very different risk profile than any factor alone. This is, of course, the beginning of multivariable thinking in medicine, because, as we know, real patients are not single variable creatures. They are not just hypertensive or diabetic or smokers. They are usually combinations of exposures, vulnerabilities, behaviors, biomarkers, and histories. Epidemiology gave us the ability to think in patterns rather than isolated facts. This is why modern cardiovascular prevention is built around risk scores. We do not treat cholesterol in a vacuum. We ask, how old is the patient? What is the blood pressure? Do they smoke? Do they have diabetes? What is their overall cardiovascular risk? Framingham taught us that the risk is not just present or absent. Risk has architecture, and sometimes when risk factors accumulate, they do not whisper, they roar. All right, now we will move from observation to intervention. Just to recap, Dahl and Hill asked, is smoking associated with lung cancer? Framingham asked, can we predict future heart disease? The Physician's Health Study asked something different. If we intervene, can we change outcomes? This is the logic of the randomized clinical trial. In this study, over 22,000 healthy male physicians were randomized to receive aspirin or placebo. That word, randomized, is doing a lot of work. Randomization is one of the most important inventions in medical evidence because it helps balance known and unknown confounders between groups. In an observational study, people who take aspirin may differ systematically from people who do not take aspirin in many ways. They may, for example, be healthier, wealthier, more health conscious, more likely to see doctors, or
more likely to have other preventive behaviors. But in a randomized trial, treatment assignment is determined by chance. That means the two groups should be comparable at baseline except for the intervention. So if outcomes differ later, we have stronger evidence that the intervention actually caused the difference. In the physician's health study, aspirin was associated with a major reduction in myocardial infarction risk. The slide here highlights a 44% reduction in MI risk with a relative risk of around 0.56. This is the superpower of the randomized trial because it does not just observe the world. It changes one thing under controlled conditions and watches what happens. That is why trials are central to evidence-based medicine. But notice something important. Epidemiology is not only passive observation. It is not just people with clipboards watching disease happen from a distance. Epidemiology can very well be experimental. It can be actionable. It can test prevention. It can tell us not only who is at risk, but whether doing something changes that risk. That is the move from prediction to intervention. Finally, we reach Interheart. By 2004, medicine already knew a lot about cardiovascular risk factors. So we knew about smoking, hypertension, diabetes, lipids, obesity, diet, physical activity, psychosocial factors. But there was a major problem. The major problem was that much of the earlier cardiovascular evidence came from Western, especially European or North American populations. So the question became, does this knowledge travel? Do the same risk factors matter in South Asia, the Middle East, Africa, Latin America, China, Europe, and North America? Or is cardiovascular risk so culturally specific that we need completely separate frameworks for every population? Interheart was designed to answer that kind of question. It was a very large, standardized case control study involving more than 15,000 cases and nearly 15,000 controls across 52 countries representing every inhabited continent. That scale matters a lot because a risk factor discovered in one city or one country may not automatically apply everywhere. And external validity is not decorative. It is not a luxury. I think, and we know that it is one of the central questions of public health. Interheart took risk factor thinking global. This study specifically asked whether common modifiable factors explained a large proportion of myocardial infarction risk worldwide. And the answer was very powerful. Many major risk factors were broadly consistent across regions. And of course, that does not mean every population is identical. Culture, diet, genetics, health systems, environment, poverty, and access to care all matter, of course. But Interheart showed that the language of cardiovascular prevention could be spoken globally. This is the fourth pillar. Dahl and Hill taught us association. Framingham taught us prediction. The physician's health study taught us intervention. Interheart taught us generalization. Together, these studies form the backbone of modern epidemiologic thinking. We observe patterns. We predict risk. We test interventions, and we ask whether evidence applies beyond the original population. And that is exactly what a serious physician researcher must do. Okay, so this is, again, the famous Interheart message. After studying myocardial infarction across 52 countries, Interheart found that most of the global risk for heart attack was not explained by mysterious, invisible, untouchable forces. It was explained by relatively small group of measurable, mostly modifiable factors. And that is the power of this slide right here. If you look at the center, we have myocardial infarction, and around it we see 9 major factors. We're talking about stuff you mostly know, like abnormal lipids, smoking, diabetes, hypertension, and what have you. So each bubble represents a factor associated with myocardial infarction risk. But the key concept here is PAR, or population attributable risk.
Parr asks a very public health question. The question is, if this risk factor were removed or improved in the population, how much of the disease burden might theoretically be prevented? So this is a different question from asking how dangerous is this factor for one individual, right? That individual level question is usually answered by things like odds ratios or relative risks. But Parr is bigger, okay? Parr combines two things. How strongly the risk factor is associated with disease and how common that risk factor is in the population. That is why a factor can become extremely important globally, even if its individual effect is moderate, as long as it is very common. Okay? So if you look at abnormal lipids, for example, this has a very large Parr, around 49%. What does that mean? That means abnormal lipid patterns explain a huge portion of myocardial infarction burden worldwide. Current smoking, for example, also has a major Parr, around 36%. Psychosocial factors are also striking, around 32.5%. This is super important because it kind of reminds us that cardiovascular disease is not only biology in the narrow sense. Stress, depression, social strain, and life pressure can become biologically embodied, right? So the heart is not floating in a laboratory tube. It lives inside a person, and that person lives inside a society. Then, for example, we see abdominal obesity, hypertension, diabetes, diet, exercise, and alcohol patterns. So together, these 9 factors accounted for about 90% of the population attributable risk in men and about 94% in women globally. This is an astonishing idea. It means that myocardial infarction, which is one of the most feared acute events in medicine, is not simply a lightning strike from nowhere, okay? At the population level, much of it is patterned. So if it is patterned, it can be studied. And if it can be studied, it can be predicted. And if it can be predicted, some of it can be prevented. But we have to be careful, okay? These percentages should not be interpreted as simple pieces of a pie that you can add mechanically. Risk factors overlap. A person who smokes may also have abnormal lipids, may also have hypertension or abdominal obesity and low physical activity. Human risk does not live in neat little boxes. The deeper lesson here is not that each bubble is isolated, okay? The deeper lesson, in my opinion, is that cardiovascular risk is a network. We're talking about lifestyle, metabolism, psychology, blood pressure, diet, social conditions. All of these connect to the same outcome. And this is why this Interheart study was so important, because it did not only say these factors matter, it said these factors matter across the world. Okay, we're talking different regions, different ethnic groups, across countries with different diets, different cultures, different healthcare systems, and different economies. So that is the global epidemiological imagination. Interheart took the risk factor concept born in studies like we've shown in Framingham, and it basically asked, does this idea survive when we send it around the planet? And the answer was largely yes. And so the clinical lesson here is when we treat a patient after a myocardial infarction, we are seeing the final event. But epidemiology shows us the upstream machinery, okay? The lipids, the smoking, the blood pressure, the abdominal obesity, the diabetes, the stress, the diet, the exercise patterns. The heart attack is the explosion, okay? These factors are the wiring, and public health is basically, in short, the attempt to fix the wiring before the explosion happens. Okay, now let's talk a bit about importance, because I think that beginners often think an important study is one with a giant sample size, crazy software, 10 subgroup analyses, and a p-value doing backflips. No, A good study is important when it answers a question that matters and does so in a way we can trust enough to act on. For this opening lecture, I would define importance using 5 filters. Relevance. So, does the question matter clinically, scientifically, or socially? A question can be statistically elegant, but useless, right? Number 2, clarity. Is the question sharp? If I cannot tell the population, exposure, comparison, and outcome, your study is fog in a lab coat. Number 3, validity. Can the design actually answer the question? An underpowered cross-sectional study with vague measurement and heavy confounding is not rescued by enthusiasm. And number 4, actionability. So, would a positive or negative answer change anything? Like, would it change practice? Would it change policy? Screening? Would it change prevention? Would it even just change at least future research direction? If not, maybe the question is still worth asking, but it is less important. And number 5, original contribution. Okay, does your research add something? So a study does not have to be world-changing to be publishable, of course, but it should contribute at least a new population or a stronger design or, a better measurement approach or a neglected outcome, a replication in an important context, for example, or a more clinically useful framing of an old question, right? That is another thing young researchers miss, in my opinion. Novelty, okay? Novelty is not only about discovering Mars. Sometimes novelty is asking the right question in the right population with the right design, and that is already rare enough. All right, so this distinction here is gold, so please do not lose it. If we talk about curiosity, we're talking about something that begins with, I noticed something. Okay, maybe my ICU patients on this antibiotic seem to get diarrhea more often, okay? Or noticing something else like women in this clinic seem to present later, or these patients with one biomarker seem to recur more. Or, for example, this community seems to have more asthma exacerbations in winter. Okay, curiosity here is the spark. It's very important, but it is not enough. And again, it's necessary, but it is not enough. Okay, the next step would be evidence question. So now we're basically taking curiosity and transforming it to become structured. Among adults admitted to the ICU, is exposure to antibiotic X associated with higher odds of C. diff infection compared with alternative regimens? You see what happened here? Now we have a population, we have an exposure, we have a comparator, we have an outcome, and we have a possible design. So right now, this is not just a thought. This is a researchable question. Okay? Now, we go one level higher, we get to a publishable research. Okay, a publishable project is not just a question. It is a question with a meaningful gap, a defensible design, measurable variables, feasible data collection, ethical acceptability, and an answer that adds something beyond noise. This is, I think, where many MDs get frustrated. They think, but I'm curious, right? Why isn't that enough? Because journals do not publish curiosity. They publish answers that are methodologically credible and situated within a literature gap. That does not mean you need $1 million and a multinational consortium. It just means your curiosity has to grow up, right? And that is one of the main jobs of epidemiology. Epidemiology takes raw curiosity and forces it through discipline until it becomes evidence. Okay, so before we close, let's hit the classic mistakes. Mistake number 1, confusing interesting with important. Okay, a weird finding is not automatically a meaningful study question. Mistake number 2, thinking statistics can save a bad design. They can decorate it, but they cannot resurrect it. Mistake number 3, using significant as if it means clinically meaningful. Okay, a tiny effect in a huge sample can be statistically significant and practically boring. Mistake number 4, thinking publication equals truth. Published papers are evidence, they're not commandments. Mistake number 5 would be forgetting the denominator, okay? If you do not know the population at risk, your intuition can betray you very fast. Mistake number 6, treating epidemiology like memorization, okay? Please, this is not a list of definitions to cram before an exam. It is more of a way of saying. Mistake number 7, jumping too fast to software. Do not start with which regression should I run. Start with, what is my question? What is my design? What is my target population? What bias threatens it? What would be the ideal comparison? Software comes later, okay? Otherwise, Excel and R will simply help you become wrong at higher speed. So let's land this properly. Today's 3 big takeaways are these. First, epidemiology is the study of distribution and determinants of health-related events in populations, with the goal of helping control health problems. It is not just about outbreaks, and it is not separate from serious clinical medicine. Second, clinical medicine, epidemiology, biostatistics, and public health are related but not identical. Clinical medicine focuses on the patient, epidemiology on populations and patterns, biostatistics on quantitative estimation, and public health on action at scale. Third, research starts with curiosity, but publishable epidemiological work requires a meaningful question, a sound design, clear measurement, and a contribution that matters. And here is your mini assignment for this episode. Take one clinical observation from your own life, something you've seen on rounds, in clinic, in the OR, or in a paper, and write it in 3 versions. Version 1, as a raw curiosity idea, okay? Version 2, as a structured epidemiological question, and version 3 as a potentially publishable study idea. That exercise alone will start rewiring your brain. And here is the question I want you to think about until the next lecture. When you say a study is good, do you mean it is statistically fancy, or do you mean it asks the right question in the right way? Because those are not the same thing. And the doctors who understand that become much harder to fool. See you in lecture 2.